Very much the organization for inviting me. I'm not a physician, I'm a gynecologist and fertility specialist. So we are going to look at this important topic. We must perpetuate ourselves, whether we are sick or not. So even those who are chronically ill still need to have children. So we must look at the ways how we can assist them. I don't have any conflict of interest, and my key objectives will be actually to review pathophysiology of infertility in renal patients. Monitoring of ovarian reserve in female renal patients is very important even before I come to that as physicians. Once these patients present to you, you need to know what is their status as far as the ovary is concerned if they don't have children. And of course, fertility preservation strategies in female renal patients. I'm also going to mention a bit of the male factor. The etiology of infertility is actually multifactorial. It's not very clear what causes, because there are hormonal alterations, as you're going to see. There is sexual dysfunction. There is immunosuppression drugs. There is dialysis, which is not very clear. Maybe I'd like to hear somebody else clearly pinpoint what could be causing the problem, because it doesn't seem to be very clear how dialysis affects that, and especially when it is recurrent, will end up affecting fertility throughout. Of course, you can understand immunosuppression than this one, but this is not very clear. It will be open to discussion to the members of the floor to contribute. We know what happens in the normal cycle is actually when the menses occur, is this production of estradiol, and of course, FSH, follicle-stimulating hormone is the most important to stimulate the follicles, and of course you have LH surge, and eventually you have ovulation there. And there's formation of the corpus luteum, which will produce the progesterone. And if the pregnancy continues, the progesterone will continue produced by corpus luteum with beta-HCG from the fetus. But what happens in perimenopause, so you can see that starts going down. When we get to about, progressively fertility gets down beyond 35 years. That's something you have to understand. That patient who presents to you above 35 years, late 30s, early 40s, and she has chronic renal disease, she has two factors which affect her. Age is critically important as far as fertility is concerned. And it's becoming more and more important because we are delaying and delaying more on getting children, and we are getting chronic illness like renal disease. So you can see that's happening. And eventually in menopause, what happens is you get estradiol and progesterone are there, and you get the FSH, LH will be very, very raised because there's no negative feedback. This is very interesting. I found very interesting because when you come to dialysis, the pattern is completely different from what you get in menopause. You get actually the LH and FSH, luteinizing hormone and follicle-stimulating hormone, are completely down, and estradiol and progesterone are completely down. Why? The effect of high prolactin levels, they tend affecting that. So you can see everything goes down completely. And that causes a lot of derangement, and that's why you have all abnormalities in the menstrual cycle, infertility, risk of premature ovarian failure, as we are going to see later on. So this is just a summary of what we have said before. It's hypoprolactinemia, because there is a lot of production of prolactin, and at the same time, there's very poor clearance because this patient has the renal disease. So that will stop the GnRH pulses, and there's no production of FSH, LH, and of course, there's no folliculogenesis, there is no steroidogenesis, there's little estradiol. So you get the whole system gets deranged completely, partly because of that raised hyperprolactinemia, and that's what causes all the problems in infertility. This is just a summary of what we have said. I'm not going to deal in so much, but you know that actually you end up in anovulatory cycles, low progesterone levels, absent estradiol and LH peaks. What we have shown before, high abnormal, or FSH levels, low estrogen, endometrial atrophy because of lack of estrogen, dysfunction uterine bleeding, and menorrhagia. Increased prolactin level contributes to this condition, and these patients actually tend to get early menopause, and with its attendant problems like osteoporosis, and of course, you know that estrogens are critically important. So something again you have to understand as a physician, these patients are at risk of complications of early menopause. This is just in men, I'm not going to deal, but we know also in men that actually we are going to have a testicular failure because we don't have luteinizing hormone and follicle-stimulating hormone. Follicle-stimulating hormone will act, is very important as far as production of the androgens is concerned and LH. So everything goes down again because there's no FSH and LH at the same time, and you end up with sexual dysfunction in this patient at the same time. And in summary, what you have said, that's happened: menstrual irregularity, sexual dysfunction, functional menopause, infertility, premature ovarian failure, and of course, as has been said before, high-risk pregnancy. Sorry. And of course, in men, again, we tend to have all those problems again. And so both these renal disease will affect both male and female factors at the same time. Again, we have the effect of the drug. I think this is the area you could enlighten more, but we know that cyclophosphamide, when you use it in glomerulonephritis, lupus nephritis, may impact fertility and ovarian reserve. Because you know that in the women, the ovaries, the folliculogenesis goes up to prophase in meiosis 1, and it is arrested. So the cell division which occurs, and it will affect both cell division when it's occurring pre-antral and post-antral, it will be affected, and therefore you'll have decreased ovarian reserve. Ovarian reserve we are talking is the amount, the quality of the follicles and the quantity of the follicles in the ovary. And so that cyclophosphamide has a negative impact. And eventually you have amenorrhea, infertility, and very high risk premature ovarian failure is something you have to understand. So those are the factors which contribute towards infertility. What interventions can we do? This is just to mention, and I talked about it. It's very important. That patient presents to you, she has renal failure. You need to know her ovarian status. And you just need to do anti-Mullerian hormone. The beauty of anti-Mullerian hormone does not change at all, like FSH and LH. You can do it at any time of the cycle. And progressively, you should monitor and see how that patient is getting on, if the condition is getting worse, and then you can advise her, either if she's not very sick, to get the children early, or to seek early intervention, because you can be able to assess how the ovary status progressively is getting worse, where it's getting worse. You have to understand age is an important factor. The ovarian reserve for somebody who is 20 years vis-a-vis who is 45 is totally different, because there's attrition of follicles. We lose follicles every cycle, hundreds and hundreds, until eventually in the mid-40s, there are no follicles at all. So when you combine that with renal failure, the condition gets worse. Very, very important, you monitor the ovarian reserve, the ovarian status of that patient. I'm not going to talk much renal transplant, but we were just saying that actually chronic kidney disease serves as a contraceptive, so successful kidney transplantation restores fertility resumption and normal menses. Restoration of fertility depends on age. That's very important, and that's why we're talking of intervention, because not everybody who has renal transplant will end up conceiving. We know the issue of the dialysis and the other comorbidities like diabetes, hypertension may affect that. If the patient has been on cyclophosphamide, we know that actually she'll be poor off. So we come to actually the gynae. And the first part actually is by the physician themselves, because you are the people who are giving cyclophosphamide. So what can you do to this patient? She's calm, she's 20, she's 30, she's on cyclophosphamide. We know it's going to have a very negative impact on her ovarian reserve, on the follicles. It's associated with destruction of folliculogenesis. It's going to affect folliculogenesis and actually end up interfering with the follicle themselves. So to minimize the risk of infertility and premature ovarian failure associated with cyclophosphamide, regimes with low cumulative cyclophosphamide doses have been developed. I think this is your area, but I'm saying that you need to do something about it. I don't know whether they're new drugs. I don't know, it's not my area. Whether they're new drugs which may not have an impact, but something you have to understand. Because we normally see these patients once in a while when they come to us gynecology, and they are not briefed at all about the impact of the renal disease on their fertility, the impact of medications on their disease process, on their fertility. You need to understand that. Co-treatment with GnRH agonist during cyclophosphamide therapy has been evaluated as an ovarian protectant. Why? Because we are going to suppress FSH, follicle-stimulating hormone, so we are going to preserve some of the follicles. But you have to understand that's not 100%, because preantral follicles develop independently. They do not depend on FSH. So that will not completely knock off the destruction of the follicles. And of course, there's decreased ovarian perfusion. So that might end up protecting the ovary. The drawback with, of course, GnRH agonist is because you get hot flashes, premature menopause, you get osteoporosis, but you can use add-back therapy where you're going to add progestins. like norethistron. So you can still add that to stop the effect of the bone loss. And this, again, that's what you're saying, that you need multidisciplinary approach when you're dealing with these conditions. Of course, when you talk about fertility preservation, we're just talking about here. This is a cycle we're talking. We can preserve the ovary as a whole. That ovary there, we can actually preserve it. And that has been done many times in oncology patients. I'm not sure about the renal patient. We can preserve the oocyte. We can fertilize that oocyte with the sperm and freeze the embryos, and we can freeze the sperm themselves. So we're talking about how we can be able to freeze that. We have said initially we may be able to protect that from drugs like cyclophosphamide. At the same time, we can be able to freeze all this, and that's what you're going to deal with. Oocyte cryopreservation, it's done very frequently nowadays for many reasons. Postpubertal adolescent and women without a male partner, because we can't freeze the embryo, then we can be able to freeze oocyte. The drawback is we have to stimulate that ovary with gonadotropins, high doses, and get very high production of estradiol, which may cause thrombosis, especially patient with SLE. But that will take about 2 to 3 weeks. So if you have time, we go to theater, transvaginally retrieve the oocyte, and actually just through vitrification freeze the oocytes. And then we thaw them, fertilize them, and subsequent transfer to achieve pregnancy, where she gets her male partner or when she wants to. And this has been known to stay for a long time. And of course, you can see Practice Committee of American Society of Reproductive Medicine have recommended that as one of the interventions. I don't know about the other African countries, but we do freeze oocytes, we do freeze embryos, we do freeze sperms, but we don't freeze the ovarian tissue. But I know that the other places they're freezing ovarian tissue for oncology patients, but I'm not sure about the renal patient. Again, still the same, we are talking that embryo preservation is very well established nowadays with very good results. Again, you have to understand IVF, the results are not 100%, they'll just be 35-40%. It can be quite frustrating. So again, this is just established fertility preservation technique. Again, we have to stimulate those ovaries, retrieve the oocyte. This is just done as a day case, do fertilization and vitrification, just be able to freeze. Again, the drawback, as you said, like the other one, is very high level of estradiol, which may cause thrombosis. So one has to be cautious if the patient has SLE. And again, if the patient is very sick, you are going to stimulate her for about 2 to 3 weeks, take her to theater. That's another risk factor again. And finally, we come to the ovarian tissue cryopreservation. This is not far-fetched. It's been done for oncology patients quite extensively nowadays, but I'm not sure about the renal patient. Maybe it's open to the floor. Again, before I go to that, let's look at this one. We had a patient, we have talked about preeclampsia, patient who have had recurrent pregnancy losses because of preeclampsia. We have used a surrogate. We did use in this country surrogate, where actually there's recurrent pregnancy losses, and we discussed with the couple, and we use a surrogate, and they got twins. So that's something, again, you have to think for renal patient. If the patient is so sick to carry a pregnancy, can you use a surrogate depending on the laws of your particular country? That's an option. That is the patient actually used recurrent pregnancy losses because of severe preeclampsia, and we use a surrogate and we got twins. So that's something, again, I don't mention, but you may consider if the patient is very sick and you have the embryos. Again, this involves removing a wedge. This is done laparoscopically. It's a very easy procedure of the whole cortical tissue or the whole ovary through laparoscopy. Ovarian tissue is cryopreserved and auto-transplanted to the ovary or peritoneum through laparoscopy surgery. It's very amazing that actually, if you know the process of cryopreservation, that it was possible to cryopreserve ovary because there's so many different cells there. But it's amazing with good results. This has been done with good results. I remember when I was in UK, one girl was 14, 15, but that's on oncology, and they just actually did froze the ovary, and many years later transplanted it with a very good result, spontaneous delivery. Successful spontaneous and IVF pregnancies. However, there is the risk, surgical risk and anesthetic risk, which may limit this option because this patient has to go to theater for laparoscopy twice. Once when you're removing you're doing a oophorectomy or the ovarian tissue, and when you're transplanting back again, that's a drawback. For Africa, of course, that is technically difficult and expensive. I don't know, I'd like to hear, I'm not aware of any country in Africa which is doing ovarian tissue cryopreservation. I don't know, I'm not aware about it. Ovary, oocytes, sperms, embryo, we're doing that, but I'm not aware about that. Of course, this you may be able to do, but sperm, again, they'll get oligospermia, but they won't completely get azoospermic most of the time, although it can happen. But of course, it's very easy and very cheap. It's something you may consider, again, cryopreserving the sperms for these men. That one we have had very good results in this patient, especially in oncology, not renal patients. So in conclusion, what you're saying is you have to be aware of cyclophosphamide. You need clear knowledge of understanding. One of the biggest problems is counseling. You need to counsel those patients clearly that there are other options. At least in this country, patients just walk in. They're not aware at all. You need to have proper knowledge and counseling and tell them there's an option. And of course, with women with chronic kidney disease who wish to preserve fertility are best served by a multidisciplinary team. I think that was said before, where you may have to involve a gynecologist. So thank you very much. You understand that humans are the only animals that have children on purpose, and that's why we are here, planning how we're going to have children, and of course, exception of groupies who like to eat theirs. Thank you very much.
Thank you very much. We'll take one or two questions.